Imagine a disease so ancient, so pervasive, it has silently stalked humanity for thousands of years, leaving behind a trail of whispers, coughs, and untimely deaths. It's been called the White Plague, consumption, and has inspired countless works of art, yet its microscopic culprit remains a formidable foe even in our modern era of advanced medicine. We are talking about tuberculosis, or TB, a disease that, despite being preventable and curable, still claims millions of lives annually, often in the shadows. But what makes TB such a persistent and devastating global health threat? Today, we embark on a deep dive into this silent killer, unraveling its origins, understanding its insidious mechanisms, and exploring the relentless fight to conquer it. Tuberculosis is caused by a specific type of bacteria called Mycobacterium tuberculosis. This tiny, rod-shaped bacterium is an obligate aerobe, meaning it needs oxygen to survive, which explains its predilection for the oxygen-rich environment of the lungs. Unlike many fast-reproducing bacteria, Mycobacterium tuberculosis is notoriously slow-growing, which significantly complicates diagnosis and treatment. Its unique cell wall, rich in mycolic acid, makes it highly resistant to many disinfectants and antibiotics, contributing to its resilience and ability to persist within the human body. Understanding this fundamental biological characteristic is the first step in appreciating the complexities of TB. The primary mode of TB transmission is through airborne particles. When a person with active pulmonary TB coughs, sneezes, speaks, or sings, they release tiny droplets containing the bacteria into the air. These microscopic droplets, known as droplet nuclei, are so small that they can remain suspended in the air for several hours, making them easy to inhale. It's not about casual contact like shaking hands or sharing food, it's about prolonged exposure in enclosed, poorly ventilated spaces. This airborne nature is what makes TB so challenging to control, especially in densely populated areas where close contact is inevitable. Once inhaled, the Mycobacterium tuberculosis bacteria travel down the airways and typically settle in the alveoli, the tiny air sacs in the lungs. Here, they are met by the body's immune cells, primarily macrophages, which attempt to engulf and destroy the invaders. However, these bacteria have evolved sophisticated mechanisms to survive within these immune cells, even replicating inside them. This initial interaction between the bacteria and the host's immune system sets the stage for either a successful immune response, latent infection, or active disease. The outcome largely depends on the strength of the individual's immune system. The most common form of the disease is pulmonary tuberculosis, which affects the lungs. However, TB is not limited to the respiratory system. It can spread through the bloodstream and lymphatic system to almost any part of the body, leading to what is known as extrapulmonary TB. This includes TB meningitis affecting the brain and spinal cord, skeletal TB affecting bones and joints, renal TB in the kidneys, and even military TB, a severe, widespread form where tiny lesions are found throughout multiple organs. The diverse manifestations of TB make its diagnosis particularly challenging, as symptoms can mimic many other conditions. The incubation period for TB, the time from infection to the appearance of initial symptoms, can vary significantly. While some individuals may develop symptoms within weeks, for many, the bacteria can lie dormant for months, years, or even decades. This phenomenon is known as latent TB infection, LTBI. In LTBI, the bacteria are present in the body but are inactive and cause no symptoms, are not contagious, and do not make the person feel sick. However, about 5 to 10% of people with LTBI will eventually develop active TB disease at some point in their lives, especially if their immune system weakens. One of the most insidious aspects of TB is its ability to remain latent. When the immune system successfully contains the initial infection, it walls off the bacteria in microscopic granulomas, forming tiny, calcified lesions. These granulomas are essentially battlegrounds where immune cells have surrounded and trapped the bacteria, preventing them from multiplying and spreading. As long as the immune system remains robust, these bacteria can stay dormant for a lifetime. This latent stage is a critical reservoir for future active disease and a major challenge in global eradication efforts. The transition from latent to active TB typically occurs when an individual's immune system becomes compromised. Factors that can weaken the immune system and increase the risk of reactivation include HIV infection, which is the strongest risk factor, malnutrition, diabetes, chronic kidney disease, certain immunosuppressive medications, like corticosteroids or biologics, and even advanced age. These conditions can disrupt the integrity of the granulomas, allowing the dormant bacteria to escape, multiply, and cause active disease. Understanding these risk factors is vital for targeted screening and preventive strategies. The hallmark symptom of active pulmonary TB is a persistent cough lasting 3 weeks or more. This cough can initially be dry but often progresses to produce sputum, which may sometimes be streaked with blood. While a cough is common, it's the duration and association with other symptoms that raise suspicion for TB. Many individuals might dismiss an early TB cough as a common cold or bronchitis, leading to delays in diagnosis and continued transmission. Healthcare providers must maintain a high index of suspicion, especially in high-risk populations, to catch TB early. Beyond the cough, active TB often presents with a constellation of nonspecific systemic symptoms. These include unexplained weight loss, which can be significant and rapid, loss of appetite, and persistent fatigue that isn't relieved by rest. Night sweats are another classic symptom, where a person wakes up drenched in sweat even in a cool room. These systemic manifestations reflect the body's ongoing battle against the infection and are crucial clues that healthcare professionals look for when assessing potential TB cases. They indicate that the infection is actively consuming the body's resources. Fever, particularly a low-grade fever that lingers, is another common symptom of active TB. This fever often peaks in the late afternoon or evening and can be accompanied by chills. While not always high, its persistence is a red flag. The presence of these systemic symptoms, combined with a chronic cough, should prompt immediate medical evaluation, especially if the individual lives in or has traveled from an area with a high TB burden, or has known risk factors. Ignoring these signs can lead to worsening disease and increased risk of transmission to others. Extrapulmonary TB symptoms are highly diverse and depend entirely on the affected organ. For example, TB meningitis can cause severe headaches, stiff neck, confusion, and even seizures. Skeletal TB, Pott's disease, often leads to back pain, joint swelling, and deformity, particularly in the spine. Renal TB might present with blood in the urine, painful urination, and flank pain. These varied presentations make extrapulmonary TB particularly challenging to diagnose, as its symptoms can easily be mistaken for other conditions. A high index of suspicion and thorough investigation are paramount. Early and accurate diagnosis is the cornerstone of effective TB control. The first step often involves a thorough medical history and physical examination. Doctors will inquire about symptoms, potential exposure to TB, travel history, and any existing medical conditions or medications that might weaken the immune system. Listening to the lungs for abnormal sounds and checking for swollen lymph nodes are also part of the physical exam. While these initial steps are crucial for raising suspicion, they are not definitive and must be followed by more specific diagnostic tests. For pulmonary TB, a chest X-ray is often one of the first imaging tests performed. It can reveal characteristic abnormalities in the lungs, such as infiltrates, cavities, or pleural effusions, which are suggestive of active TB. However, a chest X-ray alone cannot confirm TB, as other lung conditions can present similarly. It serves as a vital screening tool to identify individuals who require further, more definitive testing. Sometimes, an X-ray might show signs of old, healed TB, indicating past infection rather than active disease. The tuberculin skin test, TST, also known as the Mantoux test, involves injecting a small amount of tuberculin purified protein derivative, PPD, under the skin of the forearm. If the person has been exposed to TB bacteria, their immune system will react, causing a raised, red bump, induration, to appear within 48 to 72 hours. The size of this induration is then measured. While widely used, the TST has limitations. It cannot distinguish between latent and active TB and can produce false positives in individuals who have received the BCG vaccine or false negatives in immunocompromised individuals. Its interpretation requires clinical expertise. Interferon gamma release assays, IGRAs, such as the QuantiFERON TB Gold Plus and T-Spot.TB tests, are more modern blood tests for TB infection. These tests measure the immune system's response to specific TB antigens. Unlike the TST, IGRAs are not affected by prior BCG vaccination, making them more specific. They are also useful for diagnosing latent TB infection and can be more reliable in certain populations, like immunocompromised individuals. While more expensive, IGRAs offer a significant advantage in accuracy and can help differentiate true infection from vaccination response. The definitive diagnosis of active TB relies on identifying the Mycobacterium tuberculosis bacteria in a clinical specimen. For pulmonary TB, this typically involves collecting sputum samples. The samples are then examined under a microscope for acid-fast bacilli, AFB, after staining, a quick but less sensitive method. More importantly, the sputum is cultured to grow the bacteria, which can take several weeks due to the slow growth rate of TB. Positive culture results confirm active TB and allow for drug susceptibility testing, which is crucial for guiding treatment. Molecular tests, such as Expert MTB/RIF, have revolutionized TB diagnosis. These rapid tests detect TB DNA and simultaneously identify rifampicin resistance directly from sputum samples in a matter of hours. This speed is critical for initiating appropriate treatment quickly and preventing the spread of drug-resistant TB. Other molecular tests can also detect resistance to other anti-TB drugs. The advent of these rapid molecular diagnostics has significantly improved TB control programs, especially in resource-limited settings where traditional culture methods are often unavailable or too slow. For extrapulmonary TB, diagnosis can be even more complex. Samples are taken from the affected site. This could be a biopsy from a lymph node, a fluid sample from the cerebrospinal fluid, for meningitis, or a tissue sample from a joint. These samples are then subjected to the same diagnostic tests as sputum, acid-fast bacilli smear, culture, and molecular tests. The challenge often lies in obtaining adequate and representative samples from deep-seated or hard-to-reach organs, requiring invasive procedures and specialized expertise. Early communication between clinicians and microbiologists is key. Treatment for active TB is a lengthy and complex process, primarily involving a multi-drug regimen. The standard treatment for drug-susceptible pulmonary TB typically lasts for at least 6 months and is divided into 2 phases. The intensive phase, lasting 2 months, uses 4 potent anti-TB drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol. This combination aims to rapidly kill the majority of bacteria and prevent the development of drug resistance. Adherence to this strict regimen is absolutely critical for successful outcomes and to prevent relapse. Following the intensive phase, patients enter the continuation phase, which typically lasts for another 4 to 7 months. During this phase, the number of drugs is reduced, usually to isoniazid and rifampicin, but the treatment duration is extended to ensure all remaining bacteria are eradicated. The goal of this longer phase is to prevent relapse and eliminate any lingering, slow-growing bacteria that may have survived the initial intensive treatment. Completing the entire course of treatment, even after symptoms have disappeared, is paramount to achieving a cure and preventing the emergence of drug-resistant strains. Directly observed treatment, short course, DOTS, is a strategy recommended by the World Health Organization to ensure patients complete their TB treatment. Under DOTS, a healthcare worker or a trained community volunteer observes the patient taking every dose of their medication. This approach dramatically improves adherence, reduces treatment failures, and minimizes the development of drug resistance, which is a major global concern. DOTS has been instrumental in improving TB treatment outcomes in many parts of the world, highlighting the importance of patient support and supervision. Latent TB infection, LTBI, is also treated to prevent progression to active disease. Treatment for LTBI is typically shorter and involves fewer drugs than active TB. Common regimens include isoniazid taken daily for 6 to 9 months, or a combination of isoniazid and rifapentine once weekly for 3 months, or rifampicin alone daily for 4 months. The decision to treat LTBI depends on the individual's risk factors for developing active disease. Treating LTBI is a crucial strategy in the global effort to eliminate TB, as it targets the reservoir of future cases. Drug-resistant TB, DRTB, is a grave and growing threat. Multi-drug-resistant TB, MDR-TB, occurs when the bacteria are resistant to at least isoniazid and rifampicin, the 2 most powerful first-line anti-TB drugs. Extensively drug-resistant TB, XDR-TB, is an even more severe form, resistant to isoniazid, rifampicin, and at least 1 fluoroquinolone and 1 injectable second-line drug. These forms of TB are much harder to treat, requiring longer courses, up to 20 months, with more toxic and expensive second-line drugs, which often have severe side effects. The emergence of DRTB is primarily due to inconsistent or incomplete treatment of drug-susceptible TB. Treating DRTB often involves combinations of several second-line drugs, including fluoroquinolones, like moxifloxacin, injectables, like amikacin or capreomycin, and newer drugs like bedaquiline and delamanid. These regimens are carefully tailored based on the specific drug susceptibility profile of the patient's TB strain. Treatment is prolonged, often lasting 9 to 24 months, and can have significant side effects, including hearing loss, kidney damage, and psychiatric issues, leading to poor adherence. Research into new, more effective, and less toxic DRTB drugs is a top global health priority. The Bacillus-Calmette-Guerin (BCG) vaccine is the only currently available vaccine for TB. It is primarily used in countries with a high prevalence of TB to protect infants and young children against severe forms of TB, such as TB meningitis and disseminated TB. However, the effectiveness of BCG against adult pulmonary TB, the most common and transmissible form, is highly variable and generally low. This limitation means BCG alone cannot control the global TB epidemic, underscoring the urgent need for new, more effective vaccines that can protect adolescents and adults from developing active disease. Preventing TB goes beyond vaccination and treatment. Public health measures play a crucial role. This includes improving living conditions, such as reducing overcrowding and ensuring adequate ventilation in homes and workplaces, as these factors directly impact airborne transmission. Early case finding and rapid initiation of treatment are also paramount to break the chain of transmission. Contact tracing, where individuals who have been in close contact with an active TB patient are identified and screened, helps prevent further spread and allows for targeted preventive therapy. The global burden of TB remains staggering. According to the World Health Organization, TB is still one of the top 10 causes of death worldwide and the leading cause of death from a single infectious agent, surpassing even HIV/AIDS. An estimated 10 million people fall ill with TB each year, and approximately 1.5 million people die from the disease. The vast majority of these cases and deaths occur in low and middle-income countries, highlighting the profound health inequities associated with TB. This disease disproportionately affects the most vulnerable populations. The COVID-19 pandemic has had a devastating impact on TB control efforts globally. Lockdowns, diversion of healthcare resources, and disruptions to diagnostic and treatment services led to a significant drop in TB notifications and an increase in TB deaths. Many cases went undiagnosed or untreated, potentially reversing years of progress in the fight against TB. This setback underscores the fragility of global health systems and the interconnectedness of infectious disease outbreaks. Rebuilding and strengthening TB programs post-pandemic is now a critical priority. Research and development are crucial for future TB control. This includes developing new, more effective, and shorter-course drug regimens, especially for drug-resistant TB, with fewer side effects. The development of novel diagnostic tools that are rapid, accurate, and accessible in all settings is also a high priority. Most importantly, the world urgently needs a new, highly effective vaccine that can prevent both latent infection and active disease in all age groups. Significant investments are being made, but much more is needed to accelerate these advancements. The socio-economic impact of TB is profound. It disproportionately affects individuals in their most productive years, leading to lost wages, reduced household income, and increased poverty for affected families. Beyond the direct medical costs, the indirect costs associated with TB, such as lost productivity and prolonged disability, can push families into extreme hardship. This economic burden further perpetuates the cycle of poverty and disease, emphasizing that addressing TB is not just a health issue but also a social and economic imperative. Stigma associated with TB remains a significant barrier to effective control. Fear of discrimination, social isolation, and misconceptions about the disease can lead individuals to delay seeking diagnosis and treatment, thus contributing to further transmission. Educating communities about TB, its curability, and the importance of early intervention is essential to combat stigma. Creating supportive environments where people feel safe to seek care without fear of judgment is crucial for improving adherence and treatment outcomes. The global fight against TB requires strong political commitment and sustained funding. International partnerships, such as those involving the World Health Organization, the Global Fund to Fight AIDS, Tuberculosis and Malaria, and various non-governmental organizations, are vital for coordinating efforts, mobilizing resources, and implementing effective programs in high-burden countries. Without dedicated leadership and financial investment, the ambitious goal of eradicating TB by 2030, as outlined in the WHO's End TB strategy, will remain out of reach. Individuals also have a role to play in preventing the spread of TB. If you have a persistent cough, especially one lasting more than 3 weeks, or experience any of the other symptoms like unexplained weight loss or night sweats, it is crucial to seek medical attention promptly. Don't self-diagnose or delay. Early diagnosis not only improves your chances of a successful recovery but also protects your loved ones and community from potential exposure. Awareness is the first line of defense against this silent killer. Looking ahead, the future of TB control hinges on innovation and equitable access. New technologies, such as artificial intelligence for X-ray interpretation and portable molecular diagnostics, hold immense promise for accelerating diagnosis. However, these advancements must be made available and affordable to everyone, everywhere, particularly in the most underserved communities. Addressing health disparities and ensuring universal health coverage are fundamental to achieving TB elimination. The fight against tuberculosis is far from over. It is a battle against a cunning and ancient adversary that continually adapts. But with continued research, robust public health initiatives, strong political will, and global collaboration, we can move closer to a world free from TB. Each step, from an individual seeking care to a scientist discovering a new drug, contributes to this monumental effort. It is a testament to human resilience and our collective commitment to health equity. Thank you for joining us on this in-depth exploration of tuberculosis. We hope this video has provided you with a comprehensive understanding of its causes, symptoms, diagnosis, and treatment. Your awareness and understanding are powerful tools in the global effort to eradicate this persistent disease. Please share this information to help spread awareness and support the ongoing fight against TB. Together, we can make a difference and turn the tide against this ancient foe.